Hello everybody, I am Dr. Raktim and I am here to discuss on the topic of epidemiology of dengue. Going forward to the introduction, dengue is caused by arboviruses. They belong from the genus Flavivirus. Dengue may be asymptomatic, but it may cause three symptoms. Number one, the classical dengue fever. It is self-limiting and majority of the patients suffer from this classical dengue fever. The second is dengue hemorrhagic fever without shock, which is denoted by DHF. And the thirdly, the dengue hemorrhagic fever with shock or the dengue shock syndrome, denoted by DSS. Moving forward to the problem statement of dengue. It is the major international public health concern. About 3.9 billion people from all over 129 countries are at risk of acquiring the disease. The Americas, the Eastern Mediterranean, Southeast Asia region, and Western Pacific are the most seriously affected. India comes under Southeast Asian region and Pakistan comes under Eastern Mediterranean region. Both these countries are affected. India shows increase in dengue cases over the years. Not only India shows the number of increased cases, it also shows the disease is getting transmitted to newer areas. And as a result, outbreaks are occurring all over the world. There are around 50,000 patients of dengue hemorrhagic fever and gets hospitalized, and out of that 90% of them are children below 5 years of age. Shocking to know that 2.5% of them die every year. Continuing our further discussion, India comes under category A place for the dengue. With category A, I mean in India, dengue is one of the major public health concern for the country. Secondly, the hyperendemicity of all the serotypes of dengue virus is present all over India. And thirdly, the disease is being spread in rural areas. The reasons for such a situation in India are as follows. There is rapid urbanization in India, and that leads to the lifestyle changes of the people. There are improper water storage facilities. There may be waterlogging at times. There are, and thus there is proliferation of the mosquito breeding sites all throughout the country. And dengue also shows peak following the monsoon, and the seasonal trend is observed. Moving forward to the agent factors. Dengue, as mentioned, is caused by the arbovirus and that belongs to the genus Flavivirus. There are four serotypes: dengue virus 1, 2, 3, and 4. It is interesting that infection with one serotype causes lifelong immunity. All four serotypes are associated with dengue epidemics. However, the infection with dengue virus 2 causes the severe form of dengue or the dengue shock syndrome. The epidemics, thus, are of varying degree of severity depending upon the serotype. Before we move on to the vectors, let us discuss the pathogenesis by which the dengue occurs. The first infection by the dengue virus produces an immune response and thus sensitizes the patient. The second infection of the dengue virus leads to catastrophic in the immunity. It leads to formation of non-neutralizing enhancing antibodies, and it leads to the promotion of infection of higher number of mononuclear cells. It is followed by release of cytokines the vasoactive substances, procoagulants, and leading to disseminated intravascular coagulation, DIC. Now coming to the vectors. The Aedes aegypti and Aedes albopictus are the important vectors. Aedes aegypti is highly domesticated. It is strongly anthropophilic and a nervous feeder, the discordant species. With this, I mean the Aedes aegypti mosquito needs more than one blood meal to complete its life cycle. Thus, the Aedes aegypti mosquito bites multiple persons, thus leading to multiple cases of dengue and clustering of cases in the community. Aedes albopictus, on the other hand, it invades the peripheral areas. It is an aggressive feeder, but it requires only one blood meal to complete its life cycle. So it is a concordant species. And thus, epidemics from Albus albopictus is quite rare. The external incubation period of dengue is 8 to 10 days. It remains active for life. And it is interesting to note that the transovarian transmission of dengue virus is also seen. It means that once the mosquito is infected with dengue virus, it will lead to the transmission of the dengue virus to its offsprings. Moving forward to the environmental factors. The population fluctuates with rainfall and water storage. At 16 to 30 degrees Celsius and a relative humidity of 60 to 80% is the best for Aedes mosquito. It breeds in artificial collection of water. Example, the ornamental plants, the flower pots kept in the room, the water collected in the behind the air conditioning or behind the refrigerators, coconut shells, etc. It is both endophagic and endophilic. So it bites both outside and inside the house. Otherwise, the disease isn't present in urban areas, but it is rapidly being seen in rural areas now. I have discussed the factors for that in my previous slide. Some of the high-risk patients for severe forms of dengue, the infants and the elder, the people who are obese. At the time of pregnancy, the dengue virus can be very much fatal to the pregnant lady. Patients with peptic ulcer disease, the women who are in their menstrual period or having abnormal bleeding, they also have the at risk of having severe dengue. Hemolytic diseases like thalassemia, G6PD deficiency causes the severe form of dengue. Congenital heart disease, chronic diseases like diabetes mellitus, hypertension, asthma, chronic liver disease, and patients on NSAIDs or steroids, or those who are immunocompromised. They may have severe forms of dengue. What are the clinical manifestations of dengue? As mentioned before, it may be asymptomatic or there may be undifferentiated viral fever. There may be dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. Coming to the undifferentiated fever, it is mostly seen in infants and children and adults who are affected for the first time. It may develop simple viral fever, which is indistinguishable from other viral infections. You may see a maculopapular rash, and this rash is characteristically seen on the sixth day. And this undifferentiated fever may have associated with upper respiratory or gastrointestinal symptoms. These are much more common. Coming to the classical dengue fever. Here, I mentioned that all the age groups and both the sexes are equally affected. The internal incubation period is 3 to 10 days. There is sudden onset of high fever with chills. There is headache, muscle and joint pain, Characteristically, there is retroorbital pain and it is mostly seen. In this case, if we see all other symptoms of undifferentiated fever plus the retroorbital pain and the colicky pain, there is altered taste sensation, extreme weakness, anorexia, constipation, etc., then we may suspect this to be a case of classical dengue fever. Coming to dengue hemorrhagic fever, here it is one of the severe form of dengue fever. It also begins with high fever, flushing, headache, or other symptoms of the undifferentiated and classical dengue fever are seen, except the rash that I have mentioned on the sixth day, the rubella form rash is not that common in dengue hemorrhagic fever. Rather, here in this case, we may have symptoms of hemorrhagic like petechiae, ecchymosis, etc. Occasionally, in this case, the temperature may go up to 40 to 41 degrees Celsius. It may be associated with convulsions. The plasma leakage and abnormal hemostasis may be seen. In this case, when there is plasma leakage to a certain extent, there may be pleural effusion on the right side. It may be associated with ascites. Similarly, there may be gallbladder edema. Shock may result. Shock results when there is loss of plasma to a critical level. There would be organ hypoperfusion, organ impairment, metabolic acidosis, and disseminated intravascular coagulation. When the patient survives this 24 to 48 hours of critical period, then following 72 hours marks the recovery phase. So, in the recovery phase, the patient gradually, the general well-being improves, the hematocrit level stabilizes, and extracellular fluid gets reabsorbed. As a, as a result, the appetite returns, the GI symptoms improve. The sign of bradycardia is very common in this phase. How will you probably diagnose a case of dengue fever? When a patient with acute febrile illness coming to you with headache, myalgia, retroorbital pain, arthralgia or bone pain, rash, hemorrhagic manifestations, leukopenia, thrombocytopenia. And if these symptoms are associated with supportive serology testing or occurrence at the same location and time as confirmed dengue, so there will always be clustering of cases, and it is mostly seen uh, in the monsoon season or post-monsoon season. Then we will call it a probable case of dengue fever. When we say to be a confirmed dengue, when there is the probable case of dengue plus one of these following sign and symptoms, like when there is isolation of dengue virus from serum, CSF or autopsy, if there is fourfold rise of serum IgG or IgM antibody, and if there is detection of dengue virus by ELISA or PCR, then we will say to be a confirmed dengue case. For dengue hemorrhagic fever, the hemorrhagic manifestations like petechiae, ecchymosis, purpura is seen along with a platelet count of less than 1 lakh cells. Plus, there is objective evidence of plasma leakage like pleural effusion, hyperproteinemia, then it is a confirmed dengue patient. For dengue shock syndrome, along with the symptoms, both clinical and laboratory, of dengue hemorrhagic fever, plus the signs of shock such as tachycardia, cold clammy hands or the extremities, delayed capillary refill time, reduced brain perfusion are seen, then we will say to be a case of dengue shock syndrome. Now let us think of how to manage a patient of dengue. There are few important considerations. Number one, it is important to classify what is the severity of dengue for the patient. We must do a full blood picture count at the time when the patient comes to us. The blood count should be repeated, particularly the platelet count should be monitored on a daily basis. If there is decreased platelet count with the rising hematocrit level, it suggests the progression to plasma leakage. In absence of the baseline, then the age-specific population hematocrit levels can be used. But as far as possible, we have to do the baseline count after admitting the patient and then follow it up. Moving forward to the management, again, what we should do. The patient should be advised to take sufficient quantity of oral fluids. We have to check whether the patient has passed urine at least once in 6 hours or not. We have to encourage the patient to take ORS, oral rehydration solution, fruit juice, and other fluids containing electrolytes. Plain water can also be given. To treat headache, fever, the only medicine that we can give is paracetamol. Aspirin, ibuprofen, and all other NSAIDs should not be given. Otherwise, it may cause more harm to the patients, like aspirin may cause Ray's syndrome to the infants and children. The instruction to the caregivers should be clear that if the patient wants to go to his home, then when to return to the hospital, we have to explain it clearly. Number one, if there is no clinical improvement or if there is deterioration of the patient, then the patient should be brought to the hospital immediately. Number two, if the abdominal pain gets severe, there is vomiting, there is signs of dehydration, there is signs of shock, restless, frank bleeding from the nose, and if the patient is not passing urine for more than 4 to 6 hours. We have to instruct the caregivers that in such cases the patient should immediately be brought to the hospital for the further management. For the management of dengue hemorrhagic fever and dengue shock syndrome, firstly, hospitalization is a must. We have to advise the patient to take copious amount of fluids. The fluids may be plain water, ORS, electrolytes, etc. If the patient is unable to take fluids orally because of vomiting, anorexia, then IV fluids are recommended. Close monitoring of the patients should be done for any signs of shock and the vitals should be monitored regularly. If the IV fluids are unable to stabilize the patient, then the requirement of crystalloids is thought for. If there is severe blood loss or the hematocrit level is increased and the hemoglobin level is low, then the blood transfusion is thought upon. It all depends upon the severity and the clinical course of the disease. What are the control measures for dengue? Firstly, the breeding sites of the Aedes aegypti that we have discussed, like the artificial collection of water, it must be controlled by individuals or in a community action by using anti-adult and anti-larval measures. We would be discussing the anti-adult and anti-larval measures in some other slides or other class. However, for this, we will restrict ourselves to anti-adult and anti-larval measures. In nutshell, this we say as source reduction of the mosquito. Other measures like personal protection equipments, personal protection like the wearing of full sleeves, environmental control measures should be taken. If we say regarding the vaccines, there is one vaccine known as CYD-TDV, which is live attenuated. It is a tetravalent viral vaccine. It is given in 3 doses of 0.5 ml subcutaneously at 6 months interval. It can be given to 9 to 60 years of age and it is safe. With this, in a nutshell, we have completed the control measures of dengue. Thank you for your attention. That was all about the epidemiology of dengue. If you have any queries or concerns, feel free to ask in the comment box. Thank you very much.